This is case L3 Ct A53. The history is that of a 55-year-old man who has atypical chest pain but progressive dyspnea on effort. We start with an overall inspection of the study, beginning at the base of the heart. Aorta appears to be of normal size. As we move down, the aorta continues to be normal. Left atrium may or may not have any enlargement. The aortic valve appears to be normal and trileaflet. Examination of the thoracic aorta shows some very mild calcifications and some evidence of plaque, non-calcified plaque as well. We commence examining the overall left ventricular function. This is a horizontal long axis view. You can see here that there is clearly a severe hypokinesis to akinesis of the lower half of the interventricular septum, at least akinesis to possibly mild dyskinesis involving the apex, and preserved overall function of the lateral wall, specifically at the basilar section. This is the vertical long axis. There is severe hypokinesis, akinesis involving the entire anterior wall with probably some wall thinning, very minimal, if any, function at the apex, and reduced overall global function involving the inferior wall. We turn now to the short axis view, which again reconfirms the severe akinesis of the septum, hypokinesis of the anterior wall, very good function of the lateral wall, and some hypokinesis of the inferior wall. This patient's overall global EF is significantly reduced, probably on the order of 25 to 30%. This is the end diastolic frame of the mid left ventricle. We want to get an assessment of the overall size of the heart. We're going to make a simple standard M-mode type measurement. We're getting a cross-sectional diameter of the left ventricle at the mid-section of about 66 millimeters. Upper limits of normal is about 55, so this is moderately dilated left ventricle. Because there was some akinesis, possibly dyskinesis involving the apex, we want to get a better look at the apex. This is a thin section view of the apex, relatively scalloped outward in a normal fashion. And inspecting the area of the apex, there's nothing to confirm the presence of an apical thrombus. We now review the coronary artery anatomy. This is the left main. It appears to be normal. The distal end of the left main occurs at approximately this site, where we see a takeoff of a very small left circumflex. So the body of the left main appears to be normal. We next examine the left anterior descending, where there is found to be significant and severe disease in the proximal and mid segments with mixed calcified, non-calcified, and clearly obstructive lesions. The distal or apical LAD appears to be relatively normal. Back to the left circumflex, again, there's a very small left circumflex. However, there is also a takeoff of what might be considered a ramus intermedius, which proceeds down in the distribution of an obtuse marginal, but has in its origin or in the proximal segment of the left anterior descending very significant and obstructive mixed plaque using calcified as well as non-calcified and clearly obstructive. And return to the right coronary artery near the ostium. Ostium appears to be normal, but as we proceed in the very proximal segment of the vessel, there is clear evidence of major coronary remodeling involving the presence of non-calcified plaque and an obstructive lesion in the proximal segment. If we proceed further down into the right coronary artery, we can see that this vessel ends up being totally occluded. Here is the occluded right coronary artery. We're right here at the crux. As you proceed distally, you can see that there's no opacification of the vessel until we get somewhere near the distal segment where there appears to be some element of opacification. Unclear if there's any flow into the posterior descending artery. There may be some flow into a small diagonal branch coming off, or a posterior lateral branch, but otherwise very, very poor flow in the distal reaches of this vessel. So in summary, we have a 55-year-old gentleman who has a dilated ischemic cardiomyopathy, evidence of prior myocardial infarction, and currently has triple vessel obstructive disease and occlusive disease involving the right coronary artery.